Hi, class. My name's Will Bass. We'll be talking about exercise and diabetes today. All right, so just to lay out the differences in diabetes mellitus and metabolic syndrome, diabetes is actually a part of a larger problem of metabolic syndrome. Uh, so we'll go through metabolic syndrome first. It includes uh, increased blood pressure, high blood sugar, excess body fat around the waist, abnormal cholesterol or triglyceride levels. There's a significant increase for risk for stroke and heart disease. It's basically all of the bad stuff that you would consider uh, to be risk factors for heart disease. It's all just into one big syndrome with diabetes and like high blood sugar and all that stuff being a significant part of it. All right, so now into the different types of diabetes mellitus. Type 1, 5 to 10% of the population or 5 to 10% of the people with diabetes has this. Uh, so this is where the beta cells in the pancreas are attacked via an autoimmune disorder. It's where insulin is not made or it's not made in the same quantity as a healthy pancreas. Uh, Type 2, which 90% of the people with diabetes have, it's where insulin's made. There's just no sensitivity to it. Like the receptors are becoming fewer and far between that will actually accept the insulin slash glucose, which results in high insulin and high glucose in the bloodstream. Uh, so the elevated blood glucose comes from two different sort of methods in both. In type 1, the excess blood glucose comes from glucose in the system not having anywhere to go because it doesn't have a car to get there, aka insulin. Uh, so the elevated blood glucose in type 2 is uh, it has 7 cars that it can take to anywhere. It just doesn't have a code to get into the garage of the cells. Uh, so the receptors at the cells won't actually let the insulin slash glucose in. With this, you have a risk for neuropathies, micro and macrovascular diseases. All right, so pre-diabetes is considered when your fasting plasma glucose is between 100 and 125 milligrams per deciliter. Uh, Impaired glucose intolerant, it's basically just glucose insulin insensitive. It's a 2-hour plasma, or not plasma, but plasma glucose swab is between 140 and 199. So 2 hours after you get done eating, you check your glucose, and if it's in those numbers, you're probably pre-diabetic. Uh, for full-on diabetes, it's plasma glucose fasted above 126, and then the 2-hour above 200. So the main goal of controlling diabetes is glycemic control, in that you try to get as much uh, glucose out of the system, trying to get it back down to the normal ranges, whether that be from reducing carbohydrate intake or whether that be through increasing pathways to get glucose out via increased insulin or increased number of receptor sites. All right, so for exercise testing, it's not necessary if patient is asymptomatic for cardiovascular disease or at low risk. That's only if they're going into a light to moderate intensity program. If they're going into a moderate or vigorous intensity, you need an graded exercise test with an ECG. Uh, if a person is 35 years old or older, and they've had diabetes mellitus, if they've had type 1 for 15 years or type 2 for 10. There should also be, if you do a graded exercise test, there should also be follow-up testing considered. If the ECG is positive for CVD, or if nonspecific changes in ECG during exercise. Also at rest if the ST and T wave are a little off if there's non-specific changes. So the ACSM also recommends doing a annual cardiovascular risk assessment. So just trying to stratify their risks every year because silent ischemia can often goes undetected. Okay, so the benefits of exercise for type 2, the more you exercise, the more sites and receptors that actually open up for cellular pathways, which makes you more glucose tolerant and more sensitive to glucose. For type 1, there's a decreased requirement for glucose, or for insulin. My apologies. There's a decreased requirement for insulin as the receptors open up, and there's also glycolysis happening. So both they have reduced risk factors. The benefits of both is it's reduced risk factors, and it also can prevent or delay pre-diabetes mellitus type 2. That's a big one in our day and age, is trying to actually stop it from progressing from pre-diabetes to type 2, even if you can prevent it or possibly reverse it. Okay, so for the aerobic side of things, the FIT principles apply to both populations, type 1 and type 2. The biggest thing with both of these is typically with diabetes, you also get met with less than optimal body composition. So overall calorie kind of goals should be a little bit higher than normal. Basically, you want more calories going out, less calories coming in. It also lowers the chances of metabolic disease too. So absent of any contraindication, resistance training is encouraged, as it does show that it engages more receptor sites for insulin. Comorbidities need to be tailored with the resistance training. So if there's any kind of CVD, if there's any kind of like peripheral artery disease, like they need to kind of go in line with that. No more than 2 inactive days in a row. That's a big one in this book. Basically says that you go 3 to 7 days per week, but you should never go 2 days in a row without exercising. I think that's a rule to live by for everybody. It also emphasizes vigorous activity for CRF, and the moderate for weight loss and maintenance. Moderate because you're going to spend more time and possibly you're going to get more calories burnt throughout the whole process. So to help you maintain weight loss, or increase the weight loss. Vigorous activity for cardiorespiratory fitness. That is basically just doing almost circuitish type, going through and getting the heart rate up to between 80 and 100% of max heart rate, and then letting it fall back down and then getting it back up, or just going between 70 and 80% for the entirety of the whole duration. Okay, so for the fit principles, the frequency is 3 to 7 days per week. You would probably start off with 3 days, depending on the person's training history and willingness to want to start. Then increase to 7 over time. So the intensity started off between 40 to 60% of VO2 resting. The RP 11 to 13 is probably a better indication, as there's a propensity for chronotropic incompetence. Excuse me, within this population. The one thing that this book highlighted was that intensities was 60% or more, so that would probably be an RP of 13 plus, 13 to 20, result in better glucose control. I believe that would be because you're more getting into glycolytic than you are the oxidative pathways. So you're honestly going to be relying on glucose more so than fats at that point. For the time portion, type 2 should minimum of 150 minutes per week, moderate to vigorous exercise. It said bouts of at least 10 minutes throughout the week. I guess you could do like 4 or 5 10 minute walks throughout the day. Or you could just go ahead and get a 90-minute walk in one day and then like a 30-minute and a 30-minute just to get that time in. Greater than 300 minutes is more beneficial. That would be A, because you're getting more volume in, and B, because your calories are going up. Your calorie output is going up. For tight, large muscle groups in rhythmic fashion, it's basically anything that, not anything, but an activity that they wouldn't mind doing. So like I would choose rowing over anything else. So the progression is duration and then intensity. So you would increase the duration and then the intensity. Hypoglycemia is the biggest special consideration for this. That's what everything is pretty much about, other than the hyperglycemia. So for all of these special considerations, you're basically trying to mitigate either hypoglycemia or retinopathy or any of the neuropathies that could possibly come through. All right, so coming back, so hypoglycemia, it's basically less than 70 milligrams per deciliter, but it's all relative to the individual. It can happen up to 12 hours post-exercise. So you want to monitor glucose. You want to actually be cognizant of the insulin timing, especially for the type 1 people or type 1 people. Try to stay away from insulin enhancing drugs, as they can really cause it after. Insulin pumps need to be lowered for the 12 hours post exercise. Continuous monitoring actually can help fine tune everything. Exercise with a partner and supervised. So no ketone bodies means you're good to go. With ketone bodies means that you need to probably take a day off before you actually start exercising again. Diabetes and retinopathy, and you want the intensity low, so you can have a lower blood pressure, so you don't have to worry about severing the retina. Okay, so yeah, monitor hypoglycemia. Also monitor hyperglycemia, depending on the individual. You don't want it above the 250. I think that's the cutoff. Plan accordingly to the weight of the individual. everybody's in this is basically at high risk for CVD, or they already have it.